Good morning, everybody. For the next 15 minutes, I'll be talking on metabolic obesity, a new therapeutic target for cardiometabolic risk reduction. All of us know the global prevalence of obesity has nearly tripled since 1975 and continues to grow at an exponential rate. Cardiometabolic diseases are rocking the entire world and are important contributors for cardiovascular morbidity and mortality, and there is an urgent necessity for a cohesive approach to tackle the cardiometabolic diseases. Now, metabolic obesity, all of us know, is always associated with conglomeration of adverse risk factors, as you can see on this slide. Metabolic obesity, on one hand, is a driver of type 2 diabetes, while on the other hand, it is a driver of cardiovascular disease. And all of us know diabetes is a driver of cardiovascular disease. And therefore, metabolic obesity should be targeted at the earliest. And it is said if we could prevent obesity, type 2 diabetes would become evanescent to a great extent. And don't forget, obesity is never cured, it only goes in remission, and therefore efforts must be made continuously to minimize obesity. How to diagnose the increased cardiometabolic risk? It is very simple. One has to measure the waistline and the BMI. In the Indian context, the normal waistline for male is 90 centimeters. For female, it is 80 centimeters, and the BMI for Indians or South Asian is less than 23. If you have a normal waistline, as you can see here, and your BMI is also normal, this has least cardiometabolic risk. But if your BMI increases, the cardiometabolic risk also increases. On the other hand, if you have increased baseline to start with, even if your BMI is normal, there's increased cardiometabolic risk. But if the BMI also increases, the cardiometabolic risk goes on increasing progressively. Now, these are the figures for the Western world. The normal waistline for the Western population is less than 40 centimeters, 100 centimeters in male, and less than 89 or 90 centimeters in females. And the normal body mass index is less than 25. If the BMI is 25 to 29.9, this indicates overweight. If it is more than 30, it is obese, and we have three grades of obesity. 30 to 34.9 is grade 1, 35 to 39.9 is grade 2, and more than 40 is grade 3. This shows how do we measure the waist circumference, but this I'll skip over because all of us are very familiar with this. Now this is very, very interesting. This is a photograph of past president, American Diabetes Association, and Dr. Yagnik. Look at it. The BMI of both these individuals is 22.3, but Indians have a tendency to have higher amount of visceral fat. So when we look at the visceral fat in Indians, this is much greater, and that's why Indians are called thin fat Indians, and they may develop non-obese metabolic syndrome. How do we quantitate the visceral obesity? Now, if the excess visceral fat is more than 1 centimeter square, this indicates visceral obesity. On the left side of the screen, you can see the visceral fat area is 146 centimeters square, and the subcutaneous fat is 115 centimeters square, clearly indicating this is a case of visceral obesity. On the right side, you can see the subcutaneous obesity. Visceral obesity area is 60 centimeters square, which is normal, but subcutaneous fat area is 190, which is higher. So the right side, we have subcutaneous adiposity. The pathogenesis of obesity basically revolves around high energy foods, physical inactivity, genetic predisposition, and gut microbiota. The role is still evolving. Consumption of high energy foods with physical inactivity is one of the very important cause of metabolic obesity, and currently, as you can see, there is a tendency to upsize the food. Look at these fat kids, TV cola culture, internet cola culture, physical inactivity. You can see the individual is sitting in a vehicle and the doggy is being taken for a ride. And on the lower side of the slide, you can see the doggy is doing treadmill test. The individual is sitting and taking drinks. But the good news is we now have three bigs for treatment of obesity: drugs, endoscopic bariatric procedures, and bariatric surgery. Lifestyle modification is an integral part of all therapeutic strategies. These are the FDA-approved drugs for obesity. All these drugs, except semaglutide, they decrease weight by 5 to 10%. What are the three big drugs in obesity? Semaglutide, Tirzepatide, and Cagrilintide. All these three are blockbusters for treatment of obesity, as I'll be discussing. When we look at the GLP-1 receptor agonist, semaglutide is the blockbuster, liraglutide is less potent, and oral semaglutide, the advantage it can be initiated orally. Liraglutide, the weight reduction in 3 milligram dosage to the tune of 6 to 7 kgs, semaglutide 15 kg or more, and oral semaglutide 5 kg. This is a head-to-head comparison of semaglutide and liraglutide in the STEP 8 trial, and you can very clearly see on the right side of the screen that the weight reduction with semaglutide is minus 15.8, with liraglutide is only 6.4, clearly indicating semaglutide is distinctly superior to liraglutide. And when we look at the reduction in weight more than 5%, 10%, 15%, or 20%, it is semaglutide which always scores over liraglutide. Semaglutide has been investigated in the STEP program, STEP 1, 2, 3, 4, 5, and these are the results. Step 1, the reduction in weight with semaglutide was 14.9%, Step 3, 16.0%, and Step 4, till 20 weeks it was 10.6%, and from 20 to 68, additional 7.9%. So 17.9% reduction in the semaglutide. This is oral semaglutide, and as you can see across the Pioneer program, the reduction in weight is almost to the tune of 5 kilograms. The advantage of oral semaglutide is that it can be administered orally. This is how GLP-1 receptor agonist acts in reduction of weight. They increase satiety, reduce hunger via neurons in the arcade nucleus. Tirzepatide is another new blockbuster for treatment of obesity, still undergoing evaluation. It's not yet approved for clinical use, but very likely to be approved this year. Tirzepatide is a twin creatine therapy, a dual GIP-1 and GLP-1 receptor agonist. This is the SURPASS program for diabetes. You can see several SURPASS trials have been completed, some are ongoing. And for obesity, we have the phase 3 SURMOUNT trial, and for NASH, we have phase 2 Synergy NASH trial. Now, this is the result of all 5 SURPASS trials put together, and you can see great reduction in HbA1c ranging from 2.0 to 2.59, unbelievable but true. When we look at the reduction in weight in the SURPASS trial, again, great reduction in weight almost to the tune of minus 9.5 to 13 kg. Tirzepatide is not yet approved, but very likely to be approved for clinical use by FDA this year. And this is the SURPASS CVOT trial, 12,500 patients of type 2 diabetes with atherosclerotic cardiovascular disease, and Tirzepatide is compared head-to-head with dulaglutide, the primary endpoint being cardiovascular death, MI, and stroke. This is another blockbuster for treatment of obesity, Cagrilintide. It is once weekly combination of Cagrilintide, 0.16 to 4.5 milligram, plus a fixed dose of semaglutide injection, 2.4 milligram, and is being evaluated for obesity and NASH. Cagrilintide is a synthetic stable lipidated long-acting amylin analogs. It slows gastric emptying, suppresses postprandial glucagon secretion, and regulates food intake through centrally mediated appetite modulation. And a recent study, as you can see on the right lower quadrant, found that once weekly cagrilintide resulted in weight loss as much as 17.1% of body weight without lifestyle interventions, although we always advise lifestyle interventions. So you can see the power of this new blockbuster cagrilintide. Now this is cagrilintide dose ranging changes in body weight, and you can see with 2.4 milligrams the reduction in weight is almost to the tune of minus 17%. And this is the phase 1B trial. Again, you can see reduction in weight is to the tune of 17.1%. Research in anti-obesity drugs continues unabated, and in future we will have triple combination of glucagon, GLP-1 and GIP, and peptide conjugates may become the golden therapy against obesity. What are the three bigs in endoscopic bariatric procedure? The three bigs are intragastric balloons, sleeve gastroplasty, nutrient diverting therapies. And this shows the various procedures in endoscopic treatment of obesity, restrictive procedures, which has intragastric balloons and tissue opposition technique like endoscopic sleeve gastroplasty. And we have three nutrient diverting therapies: endo-barrier, magnetic anastomosis, and mucosal resurfacing. Now these are the panoply of balloons which are used in endoscopic procedures. There are two types of balloons. Balloons were first approved in 1985 by FDA. The first type of balloons are fluid-filled balloons, and the other type is the gas-filled balloon. The fluid-filled balloon produces greater reduction in weight compared to the gas-filled balloons. But fluid-filled balloons have more side effects like nausea, vomiting compared to the gas-filled balloons. This is data on the Orbera balloon, and you can see total weight loss is 10.5%, and this has to be inserted endoscopically. This is supposed to be kept for 6 months, but I have newer balloons which can be kept even up to 20 minutes. Nausea, vomiting occurs in small number of cases. This is the ellipse balloon. This is a soluble balloon. The patient swallows it and then it is inflated, and 450 to 515 ml fluid can be injected, and the excess weight loss is 13.7.2, and nausea, vomiting are side effects. This is a very famous Obalon balloon, which is a swallowable balloon. The procedure is performed in OPD. Patient just swallows the balloon, and then it is seen under fluoroscopy, and in the stomach it is inflated with air or nitrogen, and you can see the weight loss is total weight loss is 6.81%. Endoscopic sleeve gastroplasty is another very excellent procedure. In this, these are the three types of instruments. I will not go into detail. And this is the result of endoscopic sleeve gastroplasty. You can see on the right side, the stomach is converted into a sleeve, and this helps in reduction of weight. And this you can see after 3 months of endoscopic gastroplasty, the gastric retention at 240 minutes is substantial. Unlike in a normal individual with only 5% is retained, here nearly 30% or more of the food is retained even after an interval of 240 minutes. What is the effect on comorbidities? 76% diabetes undergone remission, hypertension 91%, 19.30 goes in remission, and OSA almost everybody goes in remission. This is the Indian data on endoscopic sleeve gastroplasty. You can see 53 patients, BMI 34.78%, duration of the procedure means 68 minutes, and the average total weight loss at the end of 12 months is to the tune of 19.94, which means 20% weight loss. So endoscopic gastroplasty is an excellent procedure. And the MERIT trial has come out positive with sleeve endoscopic gastroplasty. You can see the ESG group demonstrated excess weight loss almost to the tune of 49.2% at 12 months, which was 45% difference in the excess weight loss compared to the placebo group. What are the nutrient diverting therapies? The first one is nutrient diverting is the endo-barrier, and this basically involves placing an impermeable barrier between the food and the absorptive surface. within the foregut, so the food is not absorbed. The second type of procedure is mucosal resurfacing. In this, the duodenal mucosal resurfacing is a single minimally invasive endoscopic procedure that involves circumferential hypothermal ablation of the duodenal mucosa, resulting in subsequent regeneration of the mucosa. And before ablation, the mucosa is lifted with saline to protect the outer layers of the duodenum. And this is the magnet anastomosis, which is also a very interesting procedure. What about bariatric surgery? Bariatric surgery is the most effective way to lose weight. Bariatric surgery enhances weight loss in obese individuals who have not achieved long-term success with other weight-losing attempts. And again, there are three bigs in bariatric surgery: gastric bypass, duodenal switch, and gastric banding. The gastric bypass, in this small gastric pouch is created with bypass of the small portion of the intestine to the left side of the figure, and this is a restrictive plus malabsorptive procedure. Duodenal switch, a partial gastrectomy is created with anastomosis of the stomach to the distal ileum, that is biliopancreatic diversion. This is restrictive plus malabsorptive. And gastric bending is an adjustable gastric bending, very convenient procedure, and is a restrictive procedure only. When we look at the comparison of three bigs for bariatric surgery, the gastric bypass is less malabsorptive than duodenal switch, but is more invasive than gastric bending, whereas the duodenal switch is the highest rate of weight loss, but has the greatest risk of malabsorption, vitamin deficiencies, greatest risk of complication, but has the greatest improvement in hypertension, hyperlipidemia, and diabetes. Gastric bending, only small risk of complication, least invasive, but the reduction in weight is also least, and the improvement in the risk factor is also least. These are the facts about weight loss surgery. Obesity produces 3 to 10 years loss in life expectancy. Bariatric surgery produces 40 to 45% reduction in heart complication for patients with diabetes and obesity. And the benefits of sustained weight loss through bariatric surgery are shown below. Long-term revision of type 2 diabetes, which is very rewarding. Improved cardiovascular health and reduction in risk factor. Relief of depression, elimination of OSA, joint pain relief, improved fertility, and alleviates several other medical conditions. Whatever is the procedure, there's always a substantial loss with bariatric procedure. As you can see on the slide, this is the illustration of sleeve gastroplasty, poorly controlled diabetes with insulin and hypertension prior to surgery, but within 2 weeks the patient becomes euglycemic. This is gastric bypass. Again, you see diabetes, 7 years duration, and hypertension. Immediately diabetes undergoes resolution after bariatric procedure. This is sleeve gastroplasty. Look at this girl, hyperinsulinemia, impaired GTT, strong family history of diabetes. Post-surgery, GTT becomes normal, and there's substantial loss of weight. The appearance is totally changed. Robotic bariatric surgery. This is the most recent innovation in bariatric surgery, is the introduction of a robotic surgery. Robotic surgery for obesity has definite advantage over conventional laparoscopic surgery due to its 3D vision and precise unit multi-range instrument that add more safety, but is very expensive in the long run. This shows the comparison of the various modalities of treatment for obesity. The effect of endoscopic bariatric procedures for weight loss is greater than of drugs, but lower than that of bariatric surgery. But endoscopic bariatric surgery is becoming more popular because the complication rate is much less. But in times to come, anti-obesity drugs will be competing with endoscopic bariatric procedure and even with bariatric surgery. Fecal microbiota implantation is still in the process of. So this is the shape of the things we are witnessing, and our desire is to reverse this change. Thank you very much for your kind attention.